Hello everyone, now let us discuss about 2023 ICD 10cm coding guidelines for chapter 12, that is diseases of skin and subcutaneous tissue. Now coming to the guidelines, in the current session we will be discussing about pressure ulcer stage codes and non-pressure chronic ulcers. Let us first discuss about the definition of what are pressure ulcers and what are non-pressure ulcers. The pressure ulcers are also called as bed sores or decubitus ulcers. They are called as pressure ulcers or bed sores or decubitus ulcers are the injuries to skin and underlying tissue resulting from prolonged pressure on the skin. They mainly occur in the bedridden patients. Now coming to non-pressure ulcers. The term non-pressure ulcer was coined to designate a primary mechanism other than shear or pressure. As the term indicates, the primary mechanism is not pressure in these ulcers. It may be poor circulation such as that caused by venous or arterial insufficiency or excessive moisture or trauma, or poor healing as in case of diabetic patients. All these things may result in non-pressure ulcers. Now coming to the first thing, pressure ulcer stage codes. In this we have subcategories. The first one is pressure ulcer stages. The next is unstageable pressure ulcers. Next is documented pressure ulcer stage. And the next is if the patient is admitted with pressure ulcers documented as healed. What should be code? For patients if he is admitted with pressure ulcers documented as healed. Next is if the patient is admitted with pressure ulcer documented as healing. What is the coding guideline? The next is patient admitted with pressure ulcer evolving into another stage during the admission. These are the various scenarios which require a specific guideline. We will be discussing each of this with examples. Now first, pressure ulcer stages. The codes from the category L89. The pressure ulcers come under the category L89. Pressure ulcer. Identify the site of the pressure ulcer as well as the stage of the ulcer. This is a combination code. It identifies the site as well as the stage. And the ICD 10cm classifies pressure ulcer stages based on severity, which are designated by stage 1 to 4, unspecified stage and unstageable stage, and assign as many codes from the category L99 as needed to identify all pressure ulcers the patient has if applicable. You can assign as many codes as possible from the category L89 if the patient has many ulcers. Let us see an example. Stage 3 pressure ulcer of left ankle, which is 6 into 7 centimeters, that invades the fascia. And next is stage 2 pressure ulcer of left hip. Here patient is having 2 pressure ulcers and stages are also different, and also anatomical sites are different. So you need to assign 2 different codes. First one is stage 3. The sequencing order should be severe stage should be coded first. So L89.523, which indicates pressure ulcer of left ankle stage 3, followed by L89.222, which indicates pressure ulcer of left hip stage 2. So you can assign as many codes as possible from the category L89 if applicable. Next guideline is unstageable pressure ulcers. So assessment of the code for unstageable pressure ulcer L89 dot dash dash and 0. So here you need to fill with specific laterality and location. Should be based on the clinical documentation. These codes are used for pressure ulcers whose stage cannot be clinically determined. Unstageable should be coded only when the physician documents that the stage of that particular ulcer cannot be determined clinically. Example, if the ulcer is covered by eschar or has been treated with skin or muscle graft. Here you cannot clinically determine because of lack of proper examination. In such cases only you need to code unstageable pressure ulcer. And pressure ulcers that are documented as deep tissue injury but not documented due to trauma. Either they are covered by suture or treated with skin or muscle graft, and the pressure ulcers that are documented as deep tissue injury but not documented as due to trauma. Even in these cases also you cannot assign. And this code should not be confused with codes for unspecified stage. Whenever, in simple terms, if the physician does not document the stage, you should not code unstageable pressure ulcer. You should simply code unspecified stage. Only when the physician documents he cannot clinically determine the stage, then only you need to code the unstageable pressure ulcer. And when there is no documentation regarding the stage of the pressure ulcer, assign the appropriate code for unspecified stage. Let us see an example. Pressure ulcer of right lower back documented as unstageable. Here, the physician is documenting unstageable due to the presence of thick suture covering the ulcer. In this case, you can code unstageable ulcer of right lower back. So the appropriate code is L89.130, which indicates pressure ulcer of right lower back unstageable. Coming to the next guideline, it is about documented pressure ulcer stage. Assignment of pressure ulcer stage code should be guided by clinical documentation of the stage. Simply, physician can document stage 1, stage 2, stage 3 or stage 4. Or documentation of the terms found in the alphabetical index. And for clinical terms describing the states that are not found in alphabetical index and there is no documentation of the stage, then the provider should be queried. Here, let us see an example. Left heel pressure ulcer with partial thickness skin loss involving the dermis. Here, the documentation of terms is there instead of stage. They document partial thickness skin loss involving the dermis. And if you see the tabular list also, there you can see below this code, stage 2 pressure ulcer. Any stage 2, you can see partial thickness skin loss involving the dermis. So it indicates that this documentation leads to stage 2. So partial thickness skin loss involving dermis is a stage 2 ulcer. So you need to code left heel stage 2 pressure ulcer. The appropriate code is L89.622, which indicates pressure ulcer of left heel stage 2. Now let us see the terms that describes the stage. So for stage 1 can be coded if the physician document persistent focal erythema. And stage 2 can be documented or can be coded if the physician documents partial thickness skin loss involving epidermis, dermis or both. Or if the ulcer with abrasion and blisters. For ulcer with abrasion and blister also you can code stage 2. And coming to stage 3, if the physician documents full thickness skin loss extending through subcutaneous tissue, then you can code stage 3. And if the physician documents necrosis of soft tissue extending to muscle and bone, you can code stage 4. So these are the various alphabetical index terms that indicate the stage. Either physician can directly document the stage or he can document the related terms. In both these cases, you need to code the appropriate code. Our next guideline is patient admitted with pressure ulcer documented as healed. So whenever the patient is admitted with pressure ulcer documented as healed, healed means it is recovered. No code is assigned whenever the document has healed if the documentation states that pressure ulcer is completely healed. Let us see an example. Patient receiving follow-up examination of a completely healed pressure ulcer of foot. So in this case, you should not code the pressure ulcer code. Instead of that, you can code Z09, which indicates encounter for follow-up examination after completed treatment for conditions other than neoplasm, followed by personal history code Z87.2, which indicates personal history of diseases of skin and subcutaneous tissue. So whenever physician documents as healed, you should not code the pressure ulcer. Now coming to the next guideline, the patient admitted with pressure ulcer documented as healing. Healing indicates that the ulcer is still present. So you can code the appropriate code. Pressure ulcers described as healing should be assigned the appropriate pressure ulcer stage codes based on the documentation in the medical record. If the documentation does not provide information about the stage of the healing ulcer, assign the appropriate unspecified stage. So healing is also considered as the wound is still active. So you need to code the appropriate pressure ulcer stage code. And if the stage is not documented, you need to code the appropriate unspecified stage. There is still continuation for patients admitted with pressure ulcer documented as healing. And if the documentation is unclear as to whether the patient has a current pressure ulcer or if the patient is being treated for a healing pressure ulcer, then you need to query the provider. Patient is having an ulcer, and if it is unclear whether it is a new ulcer or a previous healing ulcer, then you need to query the provider. And for ulcers, this is for inpatient guidelines. For ulcers that were present on admission but healed at the time of discharge, assign the code for the site and stage of pressure ulcer at the time of admission. Though the ulcers are healed at the time of discharge, on the discharge note, you need to code the site and stage of the ulcers that were present on admission. Let us see an example. Patient gets admitted with pressure ulcer of left hip stage 2 and started a course of antibiotics, and the ulcer got improved and healed. Patient got discharged after 4 days. So on the discharge note, you need to code reason for admission. That is nothing but L89.222. Pressure ulcer of left hip stage 2. Though the ulcer is healed, still you need to code the ulcer code on the discharge note. Next guideline is patient admitted with pressure ulcer evolving into another stage during the admission. This is also for inpatient setting. If the patient is admitted to an inpatient hospital with a pressure ulcer at one stage and it progressed to higher stage, then two separate codes should be assigned. This is also important. Two separate codes should be assigned. One code for the site and stage of the ulcer on admission, and second code for the same ulcer site and highest stage reported during the stay. Now coming to non-pressure chronic ulcers. By this we complete the pressure ulcer codes. Now coming to non-pressure chronic ulcers, guidelines are almost similar, but the code category is different for non-pressure ulcer and pressure ulcer. Coming to non-pressure ulcers, we will be discussing about the three guidelines. If the patient is admitted with non-pressure ulcer documented as healed, what should be coded? Second is if the patient is admitted with non-pressure ulcer documented as healing. Third is if the patient is admitted with non-pressure ulcer that progresses to another severity level during the admission. Three guidelines. So let us first discuss about patient admitted with non-pressure ulcer documented as healing. For healed, it is clear that you should not code the ulcer code. You need to code Z09 and followed by personal history code. Now coming to next guideline, patient admitted with non-pressure ulcer documented as healing. Similar to that of pressure ulcer, non-pressure ulcers described as healing should be assigned the appropriate non-pressure ulcer codes based on the documentation in the medical record. And if the documentation does not provide information about the severity of healing non-pressure ulcer, assign the appropriate unspecified code. And the code category of non-pressure ulcers are L97 and L98. The category L97 and L98 are the non-pressure ulcers, and they have an instruction note to code first any associated underlying condition. So before coding this non-pressure ulcers, we need to first code the underlying condition such as diabetes, etc. If the documentation is unclear as to whether the patient has a current non-pressure ulcer or if the patient is being treated for a healing non-pressure ulcer, whether the ulcer is new or an existing one, if there is any confusion, you need to query the provider. And for the ulcers that were present on admission but healed at the time of discharge, this is also similar. You need to assign the code for the site and severity of non-pressure ulcer at the time of admission. Now let us see an example. A type 1 diabetic patient is seen in the clinic. Upon examination of her feet, she is noted to have a left heel ulcer with breakdown of skin into dermis, but not full thickness. Here the physician documents a diagnosis of diabetic heel ulcer. Here the non-pressure ulcer is due to diabetes. So first you need to code the underlying condition. And what type of diabetes? Type 1 diabetes. So the appropriate code is E10.621. Type 1 diabetes with foot ulcer. Followed by L97.421. Non-pressure chronic ulcer of left heel and midfoot limited to breakdown of skin. Here he documents the breakdown of skin into dermis but not full thickness. So you need to code limited to breakdown of skin. One more example. A patient presents on referral for diabetic right grade 2 ulcer with gangrene. Upon examination, there was swelling, discoloration and malodor with necrosis into bone. Here the documentation is ulcer necrosis into bone. Patient will be admitted to hospital for IV antibiotics and surgical intervention. The patient is a type 2 diabetic. So first you need to code the underlying condition. Here ulcer with gangrene. First you need to code E11.621, which indicates type 2 diabetes with foot ulcer, followed by I96, which is nothing but gangrene NEC or for gangrenous cellulitis. Then followed by the ulcer code L97.514, non-pressure chronic ulcer of other part of right foot with necrosis to bone. Here swelling, discoloration and malodor with necrosis into bone. So you need to take the appropriate code L97.514, non-pressure chronic ulcer of other part of right foot with the necrosis of bone. Now let us discuss one more guideline. Patient admitted with non-pressure ulcer that progresses to another severity level during the admission. In this case, similar to that of pressure ulcer, if a patient is admitted to an inpatient hospital and a non-pressure ulcer of one severity level and it progresses to higher severity, then you need to code two separate codes should be assigned. One code for the site and severity level of the ulcer on admission and followed by second code for the same ulcer site and highest severity level reported during the stay. Now let us see an example. The patient got admitted to diabetic right foot ulcer with necrosis of muscle. During the stay at the hospital, the ulcer progressed to necrosis of bone. So it progressed from one stage to another stage. And the patient was given a course of antibiotics and after 5 days, the ulcer was healing and showed improvement. The patient was discharged with antibiotics. So first you need to code the underlying condition, that is diabetic. He's a diabetic patient. So type of diabetes is not mentioned, so you need to code by default type 2. So E11.621, type 2 diabetes with foot ulcer, followed by first code for the severe stage, L97.514, non-pressure chronic ulcer of other part of right foot with necrosis of bone. This is a severe stage, followed by code at the time of admission, L97.513, non-pressure chronic ulcer of other part of right foot with necrosis of muscle. So two codes should be coded. This is for hospital inpatient setting. Now finally coming to documentation by clinicians other than the patient's provider. There are a couple of guidelines here. So the code assessment is based on the documentation by patient provider. Usually the code assessment is based on the documentation by patient's provider. Example, physician or other qualified healthcare practitioner legally accountable for establishing the patient diagnosis. It can be physician or other qualified healthcare professional. Practitioner legally accountable for establishing the patient diagnosis. And there are few exceptions such as codes for body mass index. They can be given by dietitian. Depth of non-pressure chronic ulcers can be given by nurse. Usually the code assessment is based on the documentation provided by patient's physician. But you can take few exceptions such as BMI can be documented by dietitian, that can be considered, and depth of non-pressure chronic ulcer can be documented by nurse, which is a other qualified healthcare professional, that can be considered. Pressure ulcer stage, coma scale and NIH stroke scale, that can be documented by emergency medical technician. They can also be considered for assigning the code. So code assessment may be based on medical record documentation from clinicians who are not the patient's provider. Example, physician or other qualified healthcare practitioner legally accountable for establishing the patient diagnosis. Since this information is typically documented by other clinicians involving in the care of the patient. However, the associated diagnosis such as overweight, obesity, acute stroke or pressure ulcer must be documented by patient's provider. If there is conflicting medical record documentation, either from the same clinician or different clinicians, the patient's attending provider should be queried for clarification. By this, we complete the guidelines for chapter 12. Thank you for watching. Please subscribe for further videos on medical coding and CPC training.